because a lot of these anterior saphenous veins really have an extraordinary amount of sort of a network of tributaries that patients definitely suffer a little bit of symptoms for. And then when you look at sort of additional non-saphenous reflux patterns, we really look at the segmental reflux. I think the contemporary evidence really demonstrate that superficial venous reflux is frequently segmental and hemodynamically compartmentalized rather than uniformly axial. And sort of the hemodynamic approaches such as the CHIVA or the ASVAL or ASVAL, supported by sort of randomized trials and guideline recommendations from the SVS and the AVF, really emphasize targeted interruption of pathologic reflux. The data really collectively support a strategy of segmental treatment and of avoiding unnecessary full-length truncal ablation in appropriately selected patients. So in reality, I think when you do have segmental reflux, the best options are, again, whether it's endovenous, whether it's thermal or non-thermal, it's important to treat the refluxing disease segment, not the whole vein itself. And I think the counter is true as well. When you have below the knee saphenous vein reflux, it's also important to treat the entire portion of the vein itself if it is refluxing. So it goes both ways. And I think that that's an important point as well. And again, when you look at matching the ablation technique to the anatomy, we often look sort of at isolated tributary reflux. And in these patients, although I think microfoam is very, very non-invasive and very well tolerated, I don't think we should forget about our ambulatory phlebectomy. For certain patients who may have very large ropey veins, what considered the old school ambulatory phlebectomy, I think, is still is a part of sort of our repertoire of what we use, because of the fact that it is very well tolerated. Cosmetically, it works out very well. And although during the peri-procedural period, they might have a lot of bruising, it's very temporary. And oftentimes, if patients don't necessarily wear the compression stockings and things like that after the microfoam, they can get areas of discoloration that eventually fade, but often are distressful to the patient themselves. And so again, the tip is to treat the refluxing segment and not the whole vein. And as you can see in this patient, you can see that it's not just, you can see it's coming from a portion of the great saphenous vein itself, but we didn't treat the entire great saphenous vein because of the fact that it's the tributary itself that was quite bothersome to the patient. And again, when we look a little bit for the anatomy of many of these patients, especially at the gluteal, vulvar, and the posterior thigh veins, it's really important to understand where the reflux is coming from. If it's pelvic in origin, oftentimes the best options are to really get to the source of the reflux itself. And I often do the sclerotherapy bottom-up treatment strategy, but if, of course, they have pelvic symptoms as well, investigation of sort of the pelvic portion of the reflux itself is often concurrent and will definitely help patients sort of downstream if the pelvic symptoms themselves are also present. And I think one of the tips is that this is frequently missed because the posterior portion often is sort of not traced all the way up into the gluteal or the posterior circulation, and often the recurrence of it is significant because of the fact that we do not actually get to the origin of the reflux itself. So in summary, I think that when we look at tortuous truncal patterns of reflux, non-thermal is probably the optimal treatment. Segmental, it's the targeted ablation, not the entire axial portion of the vein itself. Foam is probably the best option for these patients. In tributary, again, microfoam, but as well, the phlebectomy is great. And with perforator, thermal, in my opinion, is probably the best. And obviously, there are a lot of things that people do off-label, but on-label thermal is probably the easiest to get patients to have perforator ablation. So in summary, I don't think that there is any single optimal ablation technique for non-standard patterns of reflux. And really, we need to have precise duplex-guided diagnosis, selective symptom and anatomy-driven intervention, and of course, the use of multimodal therapy rather than relying on one technique alone. And we encourage anybody who's on this webinar to, of course, join us in AVF 2027 down in Nashville, Tennessee. Oh, Dr. Kabnick, I don't think we can hear you. I think you might still be on mute.
Yeah, that's right. Thank you. Thank you very much anyway. I'm never muted. You just can't hear me. But anyway, that being said, thank you very much for your presentation. And I'm going to turn the floor over to Professor Mo for comments and/or questions.
Thank you very much for Dr. Kiguchi and Dr. Kabnick for invitation for us. And I totally agree that duplex mapping is the most important thing to identify a typical varicose vein. And ASB and segmental and also pelvic approach, basically I agree with that. And my question is, using what is the best way to the short segmental reflux or short segmental reflux of the saphenous vein or accessory saphenous vein? What is the best treatment for that? Because if it's a short segment, it often complicated the reconsideration of the straight segment. And do you think still the sclerotherapy or laser ablation, and often radiofrequency is difficult. So what is the best treatment? Short segmental reflux and or short straight part of the accessory vein. What do you prefer to treat it?
Yeah, I think that's a great question. In my experience, it really depends. If patients have a short segment stump of the anterior saphenous vein, oftentimes they have a lot of tributaries that come off of it very, very close to the stump itself. And most often I personally do phlebectomies, but do RF at that stump if there's a 3 centimeter segment itself.
I see.
That's usually my preferred method. Of course, you could do microfoam for the entire tributaries in that area, and I've done that before. But I'll be honest, I do think it's really, really important to get that trunk, like you said, that short segment. If you leave that short segment, recurrence is quite high. And sometimes with the microfoam, I don't necessarily think it gets that area as tightly closed as a thermal would. So my personal strategy is usually, if they have the 3 centimeters there, I often just do that thermal and do ambulatory phlebectomies. In terms of if you just have a focal segment of the saphenous, I think it really depends on the patient. If they have recanalization, oftentimes it will be that they notice some tributaries coming off that area. If the tributaries are really what's bothering the patient, I usually will just microfoam that tributary plus let it drain into that segmental area itself. But as I mentioned, I do not treat the entire segment of the great saphenous vein or the small saphenous vein, just because there's a little bit of recanalization of that area.
Thank you, Robert. One more question is okay. One more question is just for the dot perforator varicose veins. Sometimes it has a reflux to the saphenous femoral junction. Sometimes it doesn't have saphenous femoral junction. In that case, do you always preserve the great saphenous vein above the dot perforator if there is no reflux?
What a great question. You know, a lot of my patients, so you're asking if there's a perforator reflux, but nothing in the great saphenous vein. What do? I just treat the perforator.
Okay, thank you very much.
Yeah.
Thank you, Professor Mo. Let's turn the floor over to Mark Meissner.
Thanks, Lowell. Great talk, Misaki. I find this segmental discussion quite interesting, and I totally agree with you on the anterior saphenous vein that you need to treat that short stump. Let's move on to the patient with a short segment, maybe a mid-third thigh segmental reflux with a large tributary. Do those patients need anything done for their saphenous vein, given the fact that I always kind of interpret the fact that they have competent valves proximally and distally, and you just have that short segment because of the tributary, and particularly, and you mentioned the ASPAL data where Paul Pitaluga's data is, particularly if it's less than 4 millimeters, that saphenous vein is going to become competent after you do that. Do we really need to be ablating these or doing anything for the saphenous vein for this short segment? I'll ask you first for short segment thigh reflux, segmental reflux, and secondly for below knee reflux. Do we really need to be doing anything other than taking care of the tributaries with either sclerotherapy or foam?
I think it's a great question. I personally think less is more, to be honest, but I know that patients are here for a reason. They don't like, probably that tributary, but I explained to them, likely we will fix this problem. I do not think that just the tributary itself, you do have on duplex a little bit of maybe focal reflux in that great saphenous vein where that tributary is coming off. We'll keep an eye on it. But as we all know, it's based on symptoms, right? It's based on symptoms. I have so many patients yesterday, for some reason, who come in with terrible reflux and they have terrible veins, but they have no symptoms. I tell them, well, you don't have to do anything if you don't want to. So I think if you keep that sort of motto in mind, if for the patient it's just the tributary, there's really no reason that you need to be doing anything with the great saphenous vein, with the caveat that I always tell patients that if you have additional tributaries, if you have any of those symptoms of swelling or any of those things, come back and we'll of course take care of the great saphenous vein if need be. And I do think in terms of the below knee, it really also depends on the patient. With patients who had advanced disease, which I don't think you're talking about, but with like CEIP6 disease, CEIP5 disease, actually, I should say from 4 to CEIP6, of course. I mean, I'm like ablating everything. If you have a vein, I'm going to ablate it. But in patients who have CEIP3 to, lower, I'm pretty, I don't actually. If they don't have any disease down there, and my ultrasound, if it's CEIP6, it only really, if it goes all the way down to the ankle, but if their symptoms are just CEIP3, I actually just only really go to like the proximal calf. But if they do choose to do an intervention at the time of the procedure, I just roll my ultrasound down to that area on the leg and see how low that sort of reflux is going. And that determines sort of where I access. And so I think that tells you that, in my opinion, if it doesn't necessarily matter for their below knee reflux, whether they have it or not, if it doesn't even concur with their symptoms themselves. Well, I wouldn't treat it.
Great. I'll ask you another question just about a different pattern, because you talked about the perforating reflux. So how about, big varices arising from a 4 millimeter perforator, either in the posterior thigh, the popliteal fossa perforator, or even in the calf. And I've seen people say, well, all you got to do is manage the tributaries with phlebectomy or foam and forget about the perforator. It's been my experience that foam really doesn't work that well if the perforator is bigger than 3 or 4 millimeters. And if you don't do something for that perforator and you just do, for example, phlebectomy, it's going to bleed a lot.
Yep.
And what do you think we have to manage the perforator in those situations?
Yes, I do, actually. Especially for, and I only treat the perforator if the patient has recurrence and if they have discomfort in that area, to be honest. So if they just have like, and which is rare, I think, of like varicose veins coming off of a perforator, I often don't necessarily treat the perforator, but if they have recurrence, even if it's painless, recurrence and pain, or discomfort, I always treat the perforator in addition to the tributaries, because I agree with you. They're going to come back, or you're really going to do an incomplete job. And these perforators are just, they're so persistent. You know, they're small but mighty and annoying.
Yeah,
but
I can add into that one, the lateral popliteal perforator. I think that's really one of the most difficult to treat, because no matter what you do, there's going to be recurrence there, basically. There are a couple of questions here that are on the chat box. One from Anil Hingarani, and he was talking about DVT or chronic DVT, not acute, but a chronic thrombus in the saphenopoppliteal area and having reflux. And the second one was iliofemoral. And what do you do with those patients that have chronic? Do you go and treat the superficial first? Do you go and treat the deep system first? What do you do?
So I think it's always the age-old question, but in my practice, and I treat a lot of these patients because we have a wound center here, is that it really depends on the patient. If their entire leg is swollen and the leg is discrepant, especially to the other leg, I think it's an outflow issue. So I often treat either with the iliacs. I never go for the fem pop, but I think Anil's probably asking, is it okay to treat the superficial first? I do. I think it's low-hanging fruit, especially if it is a patient with CEIP6 disease, CEIP5 or CEIP6 disease. I don't think it burns any bridges. People often say, does it exacerbate the venous hypertension if you get rid of it? And the valves are done for. So I'm in the camp of, if it's already disease, it's disease. It's not going to do much more damage, but it might help a patient's venous hypertension. So I think it's okay, but I always start with more bang for your buck. So if they look like it's more contributory to the outflow obstruction, I always do that first. If they've had a previous DVT in the fem pop, but their leg's not that swollen, but have a lot of tributaries in their legs that are itchy and inflamed and all of those things, I just get rid of the superficial with the patient's knowledge that they do have a DVT. There might be some complications in terms of outflow, but likely it will not be a problem. And most patients understand that, and they're okay with me getting rid of their superficial. So I think it really depends on the patient. Don't think there's a wrong way, but I do think that there's an optimal way so that the patient gets less procedures and the maximum benefit.
Thank you. We talked about the asphalt technique. We didn't talk about CHIVA and where it's going in the United States. It's something that has not been really approached very much here, but there seems to be a little bit of chatter on it. What do you think about it? And maybe you can explain it very quickly.
Yes. So, you know, I agree. It's a surgical approach. I think it was, oh my gosh, I don't know how long ago it was done, but it's sort of, it's like selective ligations to the sort of affected veins and then redirects it and restore sort of normal drainage without completely removing the veins. That's sort of a very high level overview of saying it. It's minimally invasive because it's supposed to be under small incisions and supposed to have shorter recovery times. Yeah, I think I don't know. In theory, I know that it's supposed to have a lot of advantages. And it's supposed to basically restore the normal anatomic sort of blood flow while preserving the sort of venous structure. I'm not convinced. I mean, I think theoretically, it's supposed to work. I'll just leave it at that. I would love to hear what everybody else thinks.
Anyway, I threw that question at you as a humdinger because we've actually had meetings here in Grand Rounds with Franceschi, who is the proponent of
Yes.
it, and a lot of people were going like, "Really?" You know, it seems to be located in Europe mostly. I think
Yes.
there are certain places where that may be okay to do, but
Yeah.
not as a religion or gospel, just like asphalt. I think that, as you say, it's patient dependent. I'd like, before we close, to look at a friend of mine who was a former resident, Todd Jones, and I think he's got a comment and question. He's out on the West Coast. So, Todd, if you would ask your question, it would be great if you're still there.
Oh, I don't know if anybody can hear me or not. It says host muted video and audio.
We can hear you.
Oh, you can hear me. That's okay. No, I think it's fascinating. I mean, the question with the chronic obstructive disease in the femoral, that's a great one. I actually had that patient earlier this week who's got a chronic obstructive femoral popliteal disease from multiple DVTs, PEs, but his profunda is open and he's got a lot of reflux in that leg. I think that's the only thing I would add there is that, probably he has no iliac investigation, so that might be worthwhile to get an iliac ultrasound, make sure that he's open proximally. But where my understanding is that if the profunda is still open, you're pretty safe ablating the great saphenous vein because you still have some outflow there. And then whether or not you've got reflux into your circumflex or superficial epigastric as well, where that blood flow is going. But those can be challenging patients because, as you said, Dr. Kiguchi, you have to warn them like, well, it's possible to make things worse in that scenario, but the long-standing tradition of, you can't ablate that patient because that's their only outflow is obviously not true, but they're challenging, and you're always a little bit more worried about that patient.
Absolutely. But I do think in these patients who are so advanced, I mean, these are only patients that I reserve for SEEP4 to SEEP6. Oftentimes they're so miserable, I don't want to say miserable, but they're so plagued by their venous disease that they're really willing to try whatever it is to get a little bit of relief. So I think that helps a little bit. And this is definitely not for patients who have asymptomatic like iliac occlusions. And I totally agree with you. The profunda is the most important vessel, whether it's an artery or a vein. It's the most important. It's my most favorite too. So I agree.
Any last comments, George, if it is? If not, I'd like to thank Dr. Kiguchi, Dr. Meissner, Professor Mo for joining us. And next week, we have differentiating venous leg ulcers from other pathology. The main speaker will be Raghu Kalori. The discussants will be Stephen Dean and Omar Esponda. So we look forward to seeing you next week. And thank you for joining us, and have a great day or sleep, Professor Mo.
Good night.
Thank you very much.
Good night.
Bye.
Bye.
Bye-bye.
Thanks all. Thanks for